Mr. K is a 55-year-old man who presents to the emergency department with 2 days of fever associated with a wound over his left tooth for 3 weeks. He has type 2 diabetes and is taking metformin, diamicron, and empagliflozin. On examination, there was a painless ulcer over his left foot with surrounding redness and purulent discharge. His temperature was 38 degrees Celsius, blood pressure 403 per 65 mmHg, and PR was 108 ppm. His blood glucose was 10.4 millimole per liter. Blood gases show pH 7.1, serum bicarbonate 12 millimole per liter, and serum ketone of 5.6 millimole per liter. His HbA1c was 8.3%. Our differential diagnosis is euglycemic diabetic ketoacidosis (EDKA), secondly diabetic foot infection with sepsis, third necrotizing fasciitis.
Type 2 diabetes mellitus with poor diabetic control indicated by a HbA1c at 0.3% leads to diabetic neuropathy, which affects both sensory and motor functions. Sensory neuropathy results in pain insensitivity due to the loss of foot sensation. Motor neuropathy causes foot deformity, which increases the risk of intrinsic trauma. Due to the lack of pain sensation, repeated mechanical stress leads to callus formation, which eventually ulcerates, creating a diabetic foot ulcer. Additionally, neuropathic dysfunction and impaired wound healing contribute to delayed recovery and increased susceptibility to infection. Once an infection occurs, the body initiates a systemic response leading to an elevated thermoregulatory set point and fever 38 degrees Celsius. Locally, there are signs of microbial infections such as purulent discharge, redness, and swelling. The inflammatory response then releases stress hormone, which counteract insulin action, causing relative insulin deficiency. And this will lead to failure to suppress lipolysis, decrease biosynthesis of methanyl-CoA, increase mitochondrial fatty acid uptake, enhance beta-oxidation of fatty acid, and cause excess acetyl-CoA production. Besides, failure to suppress lipolysis increases gluconeogenesis in liver. Gluconeogenesis uses oxaloacetate as intermediate. Decrease in oxaloacetate causes TCA cycle to slow down and cause excess acetyl-CoA production. Excess acetyl-CoA is diverted into ketone body production, leading to an accumulation of ketones in the blood. The excess ketones cause high anion gap metabolic acidosis, with serum ketone levels reaching 5.6 millimole per liter and pH dropping to 7.3. To compensate, bicarbonate is used to buffer excess acid, leading to a decrease in bicarbonate levels to 12 millimole per liter. Patient is on empagliflozin, which inhibits SGLT2 in the proximal tubule of the kidney. This leads to decreased glucose reabsorption, causing excess glucose excretion in the urine. As a result, glucose availability in the body decreases, leading to near-normal blood glucose level despite ongoing diabetic ketoacidosis. Glucose in the urine, increasing osmotic pressure in renal tubules. Water follows the glucose, leading to polyuria. This results in dehydration, decreased blood volume, and a drop in blood pressure.
Adjustments done for Mr. K during the acute phase in the hospital will stop the empagliflozin SGL2 inhibitor because it can increase the risk of EDKA, promote dehydration, and ketone formation. You should consider DPP4 inhibitors after recovery for additional glucose control without the ketone risk. Metformin should also be stopped as temporarily as acidosis and infection can increase the risk of lactic acidosis with metformin. You should restart after the resolution of acidosis and also stable renal function. Insulin therapy should also be started because there is severe DKA, so IV insulin infusion for 0.1 U per kilogram per hour with close glucose and ketone monitoring. The diabetic foot infection should also be managed by starting broad-spectrum antibiotics such as ceftriaxone or metronidazole, and also consider surgical debridement if necrotic tissue is present. IV NaCl 0.9%, then continue with 5% dextrose solution. Metoclopramide antiemetic should also be used if there is vomiting, and also provide KCl to treat the hypokalemia. And the medium-term adjustments after stabilization in the hospital would be to transition from IV insulin to a more stable diabetes regimen, such as basal bolus insulin, as he has poor glycemic control, and as his HbA1c is also higher than 8%. And the regimen that should be done is actually basal insulin such as Glargine or Datamir, 10 to 20 units at bedtime, adjust as needed, and the bolus insulin such as Aspart or Lispro, 4 to 6 units before meals, titrate based on post-meal glucose. And for long-term adjustment, there should be full insulin therapy for poorly controlled diabetes, and since his post-hospital glucose control is still suboptimal, then you should monitor the HbA1c every 3 months and adjust insulin doses accordingly. Thank you.